Okay. Okay. In this station, are we ready to go? Okay. In this station, I'm going to take you through some of the basics of spine imaging. Okay. Hey, somebody has unscrewed this. Can you put the screw back? Okay. And we're going to focus mostly on the lumbar spine. Okay. Uh, Although the syllabus says we do lumbar plexus, but I think the time will not allow it. I rather do something simple so that you can take this message home and use it in your practice. Now, there are a few fundamental things you need to understand about imaging of the spine. Because the spine is a deep structure, you need to use low frequency ultrasound. Okay, so this is a 5 to 2 megahertz probe. It's a broadband, means it serves multiple frequencies, and it gives you a divergent beam. So if you see here, it's a divergent beam, so it gives you a wide field of view, and imaging can be quite good even in deep structures. The low frequency will penetrate deeper and it'll give you good visualization. Okay, one. Two is, I like you to think about, this is the, say, the dural sac, okay? If this were to be the dural sac, which is running through the spinal canal, it's kind of wrapped around by bone, right? Okay? Now the only way you can see this neuraxial structure is if you know where the openings are. You understand? Now, if you see, bone per se is impervious to ultrasound. So ultrasound will strike it and get reflected back. So you would get a very bright structure and then an acoustic shadow. You follow? So whenever you see bone, it's kind of your friend because you know that it's there. There's a bone there and there's an acoustic shadow. Whether the person is 15 years old or whether the person is 100-year old, the bone will always be there. But the acoustic windows will be narrower and narrower as age increases. Okay, so now the important thing is to identify where these crevices are in this complex spine anatomy. So when I first started doing imaging, I found that it was very difficult to really objectively determine what structures you're looking at. And unless you know what structures you're looking at, then you can't really say this is the internal interspinal space or it's the interlamellar space. Okay, so the first fundamental basis of spine imaging is to know, to recognize the osseous elements. There are many osseous elements, as you know. This is the spinous process, this is the lamina, this is the articular process, right? There's a superior and an inferior. They articulate to form the facet joint. Laterally you have the transverse process. So you see here that if you see in the midline you have a spinous process, the lamina, and further down you see the articular processes, facet and the transverse process. Okay, so these are the basic osseous elements that you see here. Secondly, how do we recognize this? It's something quite difficult because there's often wrapped around by a lot of muscles. Okay, so we developed something called a water phantom, which you can read about and you can learn it once, you can teach it thereafter. So I cooked something up for you because I don't have a water phantom. So when you scan the phantom through water, these osseous elements create a very specific type of sonographic appearance. Now when you do the imaging of the spine, you can imagine this is the ultrasound transducer. I could do a transverse scan, okay? Or I could do a sagittal scan. Now the transverse scan could be at the level of the spinous process or between the two spinous processes. So this would be a transverse spinous process view. This would be a transverse interspinous view. The osseous elements that you will see during these scans would be totally different. Similarly, if I did a sagittal scan, it would be a median sagittal scan. Median means middle. Then it could be a paramedian sagittal scan at the level of the lamina, paramedian sagittal scan at the level of the articular process, and the transverse process. So there is a progression of scanning the plane, and you can utilize this. For instance, say I'm looking for the lamina and I see the articular processes. It's telling me I'm too lateral. I need to go more medial. And this is one of the errors that the practitioner yesterday was having. He was looking at the articular process, trying to put it into the spinal canal. That's why they were hitting the bone all the time. But anyway, it's something you will learn by practice. So also finally, it's important to understand that while you can image the spine, it's not really necessary to do on a day-to-day basis real-time interventions, okay? the information that you can accumulate by doing a preview scan gives you a wealth of information that you can use to supplement what your skills are. Follow what I mean? So this is the basis of what I'm going to show you. Could you lie down again? Now, firstly, while we are preparing, look at this. This is a transverse spinous process view. You will see a bright dot and there will be an acoustic shadow that will be consistent with what a spinous process looks like in the transverse view. It is a transverse interspinous view. Now see, the spinous process disappeared here, but now you are seeing other osseous elements. You see, these are the articular processes. Can you see there? These are the articular processes in the lateral aspect. This is the spinal canal. These are the transverse processes laterally, see? Okay? So, while this can be very useful to locate the midline, right? If you can't palpate the spinous, it's very objective. This can be used to see if there's any asymmetry in the vertebra. Like your ears are very symmetrical. If your ears are not symmetrical, you have torticollis. But if they are asymmetrical, if this is asymmetrical, that means there is a rotation in the vertebra. Say, for instance, it's like this, then you know there is a clockwise rotation. If it's like that, then you know there's an anti-clockwise rotation. But your scan has to be correct. Also, I like you to point out that this is the anterior complex, we call this. Normally you see the posterior surface of the vertebral body. There's also the posterior ligament and the anterior dura. When we were doing our initial research in this area, we said, how do we nomenclature this? Because there was no nomenclature. So I said, we should call this the anterior complex because we have no business over there. If you try to put your needle in the anterior epidural space, ma'am, you have a problem. Right? So, and it's very difficult to define what these structures are. And they're often a composite hyperechogenic echo. So if you can see this as a single echo, it's good enough because this becomes your anterior complex. Okay? So this is the anterior complex, whereas here will be the posterior complex, which is more relevant for you. And I'll show you the relevance of this. Next is now, when you do a sagittal scan, in the midline we would normally see the spinous process like this. But this is not very practical because you know how the spinous process looks when you do it. So this is much easier than this because the spinous processes are often, even in normal individuals, they are not lined up. Okay? There may be some variation. So when you do the scan, you may see L3 but no 4 and then suddenly 5. It's not because there's abnormality, it's just that there's some deviation, and the ultrasound being so thin, you can't recognize. So I don't find this very useful. So the paramedian window is much useful. So you can see here, as we go from medial to lateral, you'll see the lamina first, okay? It looks like the horse head, you know. Okay, these are the interlamellar spaces. So this is basically the stairway to heaven if you want to put the needle. And if you go further lateral, you will see the articular processes. They're different, see? There's no gaps here. And there's no anterior complex here because the anterior complex would be here, right? And these are the transverse processes you see in the lateral aspect. Finally, when we do neuraxial blocks, we often use the intercrystal line, right, to determine what level you're performing the intervention. But realistically, when you look at the intercrystal line, it's only accurate in about 40% of individuals. So we really need to know how to determine the intervertebral level that you perform the scan. And you can see here's a good example because there's very poor correlation between the intercrystal line in this individual and the level that we are scanning. It relies on your ability to identify this gap here, L5 and S1. The sacrum is a very large surface. The first gap that you will see between the lamina of L5 and S1 is the L5-S1 gap. It would appear like so. You see, there is a large flat surface of the sacrum, and then the first lamina you see will be the L5-S1. So this is the L5-S1 gap. Once you find L5, you can move the probe cranially. You'll find 5, 4, 3, 2, 1, whatever, okay? You don't want to go that high. 3, 4, 5 is good. Okay, so let's do the scan and have a look and see what you can do. Then we divide ourselves into 2 groups, and then you can have a little hands-on. Okay, so firstly, I'm going to place the probe on the back, and my goal here is now just to look for the midline, okay? This is going to be right on a transverse scan. This is going to be head or cranial on a sagittal scan. So I'm going to place it here over the midline somewhere. Okay, right. So now can you recognize the spinous process I showed you? Can you separate these out just for those people who are a little slower than the others? Okay, this is the spinous process with the shadow. These are the lamina. So when you see it, you try to centralize it, and what you will find is that most transducers today have a mark like this. So just put a mark there, and that will be your midline. Now, sometimes putting the mark, I give you a tip, don't tell anybody. When you put your mark here, that mark will disappear because these are all washable markers. You know, you have the needles, the cap of the needle, yeah? So don't put the needle, throw the needle away, take the cap and just press it on the skin and just rotate it like this a few times. It leaves a mark there. So that's a very good mark. Even after you clean with alcohol, spirit, before he goes home it disappears, but not for long. Okay, so it stays there for some time. Okay, so you can use that. So it's a good marker. So now once we find this, I'm going to find you the other window. Okay, so this is a transverse spinous process view. I'm going to slide the probe caudad, okay? And you see what happens? The spinous process shadow will disappear. You see there? Now you see the articular processes here. You can also see the facet joints. This is the anterior complex. And this is part of the posterior complex. You can see the posterior dura here. Can you see that? Okay. So this can be useful if you're looking for symmetry of the vertebra, any rotational defect. In this case, it's quite symmetrical, so there is no scoliosis. It can be like your malampati of your spinal and epidural, if you may. You can also use it to measure some distances. A very simple tool, you can just use the caliper and measure what the predicted depth to the dura is. There's very good correlation between this and the eventual distance, but remember, it's not going to be 4.29, okay? There is some compression, so there will be some variation. So usually within a centimeter, should reach the thecal sac, okay? It's like somebody saying, if I go past 4.29, what should I do? I said, I don't know. I would go further. But up to you, you just use your common sense. If you're doing a spinal, you need to see the CSF efflux. If you're doing epidurals, the ultrasound is not going to tell you the needle has entered the epidural space. You still have to use loss of resistance. So that's one limitation. So these are by far what you can use to use the transverse scan. But again, you see here, the anterior complex is quite wide. That means that space through which the ultrasound is going, particularly this space here between this and this, is wide, okay? So therefore, this is a good space to perform the spinal. So again, as I say, that you don't have to do real-time spinal all the time. By doing this information, you can find how deep it is, where is the midline, which space would be the most appropriate, what size of needle do I need, especially in morbid obese individual. And these kind of information can supplant your clinical skills, and you will find that your success rates are much better for the experienced ones. And those who are beginners, they understand the anatomy much better, and their learning curves are much faster, okay? So these are some of the applications. Now let's do the sagittal scan. This is cranial, so I'm going to place the probe now. It is a common error when you do this sagittal scan is that you think you are doing the scan on the non-dependent side. This is non-dependent, this is dependent. But actually the transducer is on the dependent side, and you see structures which you really don't understand. Because when you do a sagittal scan, there is a need to tilt the probe slightly medially. And you can see here that if I tilt the probe medially, most of the wider part of the interlamellar space is a little bit more wider. Can you appreciate that? Yeah. So the same applies here. Now if you are on the dependent side, then you should really tilt it like that, yeah? But if you are in error, you will do this. You're going to go away from the neuraxis. So palpate the spine before you put the probe and just put it on top of it. So you now know you're on the non-dependent side, yeah. Good, so I'm going to start from the sacrum. You see here, this is the large flat surface of the sacrum, okay? What is this? L5 what? Is it? Spinous process should be here, right? Hello? Lamina, okay. L5 lamina, okay. So that is like a horse head, okay. So you see the lamina of L5, this is the lumbosacral junction, L5, L4, and this is L3. Can you see? 3, 4, 5. Once I have 3, 4, 5, I'm going to put a few marks on his back. See, I've already prepared it last. You see, I put 2 marks here and I join it, okay? Now, the advantage of this is you should put the mark slightly away so that when you are preparing your patient with alcohol, hebetane, whatever your protocol says, often these get all wiped away. So I told you a simple tip for the midline, but I don't recommend you put too many marks. So it's better to just put a mark away so that you can join it, and when you are scrubbing him, just leave that area. As long as you know that between these 2 lines, I'm looking at 3, 4, 5, okay? Right, so let's do that again. So I start from the sacrum, and I'm going to translate the probe slightly caudate. I know I'm seeing the lamina, okay? Right, the articular process would look like this, see? Can you see? There's no gap, and there's no anterior complex here, see? If I go more laterally, I will start to see the transverse processes. Can you see there? This is the transverse process with the trident and the psoas, whatever. So for neuraxial imaging, you want to see the lamina, and when you see 3, 4, 5, you will have to tilt the probe slightly medially. See, this is a true sagittal scan, okay? You can barely see the neuraxis, okay? You can see a little bit of a narrow thecal sac, but when I tilt it, well, look what happens. You tilt it, the dura becomes clearer. Can you see that? It becomes much clearer, the ligaments have become clearer, and all the structures are quite well defined. So what you see here is, this is the muscle, this is the ligamentum flavum, this is the posterior dura, this is the epidural space here. You can see a few millimeters wide. The hypoechoic is filled with fat, so it'll appear black, okay? This is the thecal sac with the anechoic fluid. This is the anterior complex. Again, it's telling you that this is a wide space. So sometimes in difficult spinals, when you're doing a scan, somebody calls you or you are doing it and you find it's very hard, just abandon it and have a quick scan. You will find that maybe the space you are doing it, you can't see the anterior complex. This could be avoided if you had done a scan before. So proactively, if you preemptively, if you do a scan, you will know exactly. Of course, in the elderly, their spine will not look like so beautiful like this. It'll be a small space, and you'll be wondering, what did he show me there, and what I'm seeing here? It's not because of you, it's because of the patient. So the width of this often correlates with how wide the space is. And if you can see a space, that means there is a hole there. And that is the same opening through which you can guide your needle. And that's all the information sometimes you need for an experienced individual. Because if I know there is a gap between L4, L5, I can look for L4, L5, put the needle paramedian, and find my way. Because I know there is a hole. You can walk your way along the bone, and boom, you will be there. Okay, so that's how you can apply this. So this is by far how you can use spine imaging. Okay, now in real time you can insert it in real time, but it's something which should come. It would come later on in your learning process. Okay, so for now I would just divide ourselves into 2 groups. You should have a little hands-on experience so that you know exactly what we're looking at. Okay, so can you split up into 2? I'll show you that. There is a box over there for 100 ringgit. So at this stage, you really don't want to know what level, whatever. I just want to see the midline, okay? And you have seen this, then you mark your transducer position and put a mark there, okay? Then you know that that's the midline. And then we just go to the interspinal space. Let's look at this one. Okay, you can see now the spinal, that's the posterior dura there. You can see a wide anterior complex with the lateral elements are the articular processes. They're very symmetrical. So this should be a good space to perform a spinal in him if I were to do it, because you can not only see the dura, but you can see all other structures, okay? You don't have to measure it all the time. Now you look at the scale on the right hand side of the screen. Yeah, it's about between 4 and 4.5 centimeters, okay? 4.253, something like that would be a good guesstimate as to where it is. and that should give you a rough idea. In some morbid obese individual, it may be 8 centimeters. So you need a long needle, because you'll be otherwise using that needle all day long. You'll never get CSF. Okay, so let's do a sagittal scan now. As I mentioned before, it's better to do with how the orientation is. This is head, okay? Yeah. Palpate the spine with your left hand and place the probe there. Yeah. Train your left hand, train your non-dominant hand. Okay. Are you right-handed?
I'm right-handed.
So use your left hand, ma'am. Yeah, good. Okay. And start the scan from the sacrum. Okay. Now you see the orientation is upside down, right? The sacrum is over there, see? Can you see? So we need to go like that. Okay. Because when you insert the needle, it will come from here, right? So you want to see the needle come from here rather than like this, okay? Right, that's good. So that's your sacrum. That's the lamina of L5, 4, and 3. So you can see now, if this is 3, 4, 5, we have already marked the back, see? You see here, right? There's a 3, 4, 5. Now try to optimize the 3, 4, 5 image. Now, this is something I need to do it with you. You watch the image as to how it is forming, okay? This is the sagittal scan, right? You can see here. So you need to tilt it. There's also some slide. Don't look here. I want you to feel it rather than look at it. So you do a sagittal scan, oblique, but there's also some sliding motion. Can you see?
Yeah.
Now this is when it's much better. So this is the angle at which the beam is entering the spinal canal to the widest spot. So if you can keep that angle image still, this would be the ideal window through which you can enter the neuraxis, okay? So you can see the epidural space very clearly. So when we do real-time epidurals, we guide the needle to the ligament, and then you put the transducer down. And then we just use our loss of resistance, because the sensitivity of ultrasound is not so good today to tell me the needle tip is in the epidural space. I still have to use another surrogate, which is foolproof, loss of resistance to saline. Okay, you need to see the articular. This is the lamina, okay? These are the lamina. These are the articular processes, all right? And that's your transverse process. Okay, transverse process also much deeper, see? More anterior. Can you see that? You can see it in this spine model. The transverse processes are much further anterior. Okay, it's gone. Never mind. Okay, so that's it. So, next.
So you still need to do the loss of resistance, is it?
Yeah, of course. We don't have 3 hands, so we're not like Shiva. We have Indian gods who have many hands, you know.
Transverse, right?
Yes, ma'am. Transverse, so I'll just put it there. And you try to see, okay, you're seeing the spinous process. Yeah, this is actually the tip of the spinous process. When you see that bright dot there, see? Can you see that bright dot?
Yeah. On top. Yeah.
That one, yeah. That is the tip of the spinous. So if it's not bright, then it's usually the proximal or distal part of the spinous process, okay? So that's the spinous process. And then we look for the interspinous scan, see? Okay? Right? It's so close. See, it's just a case of moving it back and forth. And this you already know. This is the interspinous space. You can see the articular process. So sometimes in difficult cases, when you do the interspinous scan, try to tilt the probe a little bit craniocaudally, because it may also tell you the direction at which you should insert the needle. If you can see the dura very clearly, then that is the angle at which you should really insert the needle. So it's not always mandatory to insert the needle with a Caffellad angle. But in difficult spine, sometimes you will find that it's easier when you have a little Caffellad scan, and then the dura is better seen. Okay? Now, what are we doing? You should start from the sacrum. Okay? Start from the sacrum. We see the lamina of L5, 4, and 3, right? Now we've put the marks on the skin, so this should be your normal thing to do first. See L3, 4, 5, okay? And then in order to see the neuraxis, you have to tilt the probe and slide it a touch. Can you see that? Okay, so L3, 4, 5, and you can see the And this is the articular process. This is the transverse process.